when patients are presenting with these symptoms like gas and bloating, things like this, just as you mentioned, that seem relatively benign to the average individual, when you delve a little bit deeper in that and you understand that, okay, these things are happening pretty quickly after you eating, that tells me that the dynamics of the microbial environment are not what they should be, because that's just not how that happens. You're ending up, in the restroom. You're complaining of intermittent diarrhea. It's just a lot of things that we would hear about that get blamed on IBS. And then when you start looking at these patients from an IBS model and begin to look at things more neurologically and look at some of the underlying pathology or causes behind IBS, you realize that this isn't really adding up for a portion of these patients, and there has to be more. We have to go back to this microbial conversation and figure out what's going wrong. And literally, for so many people, of which we'll talk about the causes, it becomes this overgrowth in the upper portion of the small intestine that goes unaccounted for. And the symptomatology behind it is not only annoying to the patient, but what most people overlook with this, and this is also what I think is so problematic, is that the list of conditions that are now associated with SIBO that has gone undiagnosed and the sequelae of dysfunction that's a link to it is significant. It's not a benign condition by any means.
Before we get started, I want to tell a personal story about my mom and Lifeline screening. You may have heard me talk about my mom's peripheral arterial disease diagnosis about 5-10 years ago. And I wanted to let you guys know how we found out about it. She's not a doctory kind of girl, and she has white coat syndrome. So it was very challenging for us to get her tested for different cardiac issues. So I got a postcard in the mail about Lifeline screening, and I went ahead and contacted them and brought her to basically like a pop-up, which was at a church, a local church. And she went in, and it was very quick and easy. She didn't seem to be super nervous about it. There were a lot of people milling around. And they found the peripheral arterial disease, sent us a report. We went to the cardiologist, started using diet and nutrition and exercise therapy to treat it. And I've since gone to the Lifeline screenings myself, as well as my other family members, because it was super cost effective, keeping us from having to pay multiple copays and travel time and things like that. So Lifeline screening is offering 5 preventive health screenings for a special price for my audience of $149. The package includes a carotid artery screening, abdominal aortic aneurysm screening, atrial fibrillation, which is also called AFib screening, peripheral arterial disease, PAD, which is what my mom was screened for, and osteoporosis screening. In addition, you can add other options like liver and kidney function and the A1C marker, which is for diabetes. So I can't encourage you enough to check it out. It's well worth it. It's going to save you a lot of time. It's painless. And you can click on my show notes in order to get the offer for $149, or you can call 844-558-0996 to schedule your appointment. That's 844-558-0996. Hello, and welcome everyone to A Modern Healer's Journey. This is my YouTube show, and I'm also on Rumble. My name is Tammy Bennett. I'm a doctor of Oriental medicine, and I am working to help give you knowledge and information so that you can take a control over your health and wellness and that of your family. I am pleased today to introduce Dr. Arland Hill, and we're going to talk a little bit about something called SIBO. And I'm going to ask Dr. Hill to give us his credentials and tell us how he does what he does and what he is up to and what we can learn from him.
Hi, Dr. Bennett. I appreciate you having me on with you today. Just to give you a little background of who I am, I'm a doctor of chiropractic. I also hold a diplomate with the American Clinical Board of Nutrition. And somewhere amongst all that, I ended up with a master's in public health as well. So I kind of like to look at this and say, I feel like I can look at things from a clinical standpoint as well as understand what's going on at a societal level and be able to bridge the gap between those two to help make recommendations for patients. I've been doing this for actually over 2 decades now, which is somewhat hard to believe sometimes. But from day one, I really had a fondness for nutrition and delving into what the role of nutrition was in a lot of the conditions that we hear about, and even some of the ones that we don't hear so much about, like what we're going to be talking about today with SIBO. SIBO is an interesting condition in that it's one that I see very prevalently in the population. A lot of my patients, new patients at the time we start working together, this is one of the conditions that we end up initially having to work through to ultimately get to whatever some more of their core issues are. But when you look at the data and the research behind this, and even if you look at how this is discussed in the conventional arena, it really isn't discussed that much. It's talked about in the research environment, but a lot of practitioners just don't even put this on their radar. They think about things like IBS and inflammatory bowel conditions, but really a lot of this needs to start with a conversation around SIBO, which we're going to have today.
So to clarify for the audience, SIBO is small intestinal bowel overgrowth. It sounds very benign, like it could be treated very easily. My understanding is that it is an undiagnosed condition that goes on for long periods of time because it's often called IBS in the traditional medicine world, and then it's kind of chalked off into that category. How did you become familiar with SIBO as a practitioner and as a researcher? And tell me about this whole misdiagnosis thing, why it's so often overlooked.
Well, how I ended up to have such a familiarity with this conversation is that from my outset in practice, I was doing stool testing, working with the gastrointestinal tract, and at some point you just realize I'm missing something with some of these patients, and there's something more to this conversation. And a lot of the conversation was focused around, when I would go to seminars and things of this nature, it was focused around what was happening in the large intestine. There wasn't as much information placed on the small intestine. And then information started to arise about what was happening in the small intestine, the dynamics of how that environment is so significantly different in terms of the microbial makeup compared to the large intestine. And then from there, looking into the research, it just became a natural evolution for me to start delving more into that and being able to have this discussion with patients and realize that when patients are presenting with these symptoms like gas and bloating, things like just as you mentioned, that seem relatively benign to the average individual, when you delve a little bit deeper in that and you understand that, okay, these things are happening pretty quickly after you eating, that tells me that the dynamics of the microbial environment are not what they should be, because that's just not how that happens. You're ending up, in the restroom. You're complaining of intermittent diarrhea. It's just a lot of things that we would hear about that get blamed on IBS. And then when you start looking at these patients from an IBS model and begin to look at things more neurologically and look at some of the underlying pathology or causes behind IBS, you realize that this isn't really adding up for a portion of these patients, and there has to be more. We have to go back to this microbial conversation and figure out what's going wrong. And literally, for so many people, of which we'll talk about the causes, it becomes this overgrowth in the upper portion of the small intestine that goes unaccounted for. And the symptomatology behind it is not only annoying to the patient, but what most people overlook with this, and this is also what I think is so problematic, is that the list of conditions that are now associated with SIBO that has gone undiagnosed and the sequelae of dysfunction that's a link to it is significant. It's not a benign condition by any means.
When I looked through the research that you sent me to prepare for this interview, I was really surprised myself. I had worked with a nurse practitioner years ago who was very SIBO knowledgeable, and she mentioned it almost in every case of female patients coming in with gas and bloating. Not as many male patients. I noticed in the literature that females have a tendency to have SIBO more often. But what was interesting to me was the fact that most docs, gastro docs in particular, when people go in for those complaints, weren't really going there. I mean, it was not even discussed. So I guess when you had are you still actively seeing patients in a practice?
I am.
Or are you just doing research?
I am.
Okay. So when you're doing your clinical work and you're working with a patient and you hear, what key things do you hear when your signals go off and you go, got to look for SIBO?
Yeah, the main things that come in are immediately what makes me go down that road: gas, bloating, distension, and the time frame associated with that is what's really important here. If it starts happening very quickly after eating, if we're talking within 30 minutes especially, but certainly within an hour after eating, as we think about the dynamics, that means that food hasn't been in the GI tract that long. So it hasn't had an opportunity to get that far down the GI tract. So that means we're in the small intestine, probably leaving the stomach into the small intestine at that point. So those are typically where I start to immediately think about that. And then after that is changes in motility. So I will often ask questions to patients and say, just start out when we start talking about bowel habits, tell me how many bowel movements you have a day. And if patients tell me that they have a limited number of bowel movements per day or not even one per day, that becomes a red flag too. Or if they tell me they do have those, but they don't have frequent bowel movements, but when they do, they're extremely loose or even what we would classify as diarrhea. Those are all red flags. And those are the things that I look for symptomatically. But then I like to be able to correlate that with their history. So, for example, if they have conditions that are neurologically oriented, or if they have conditions that are otherwise related to the gastrointestinal tract, those are all indications that I'm probably more and more looking towards SIBO as what I need to be thinking to follow up on.
So let me go back to something you said. When gas, bloating, and distension within a half hour, don't most people link that in their heads like food allergies, or most practitioners that are in the holistic realm kind of go there?
They do. Indeed, they do. And I think the bigger question we have to ask on that is not so much whether it's a food allergy or not, is that even if it is a food allergy, what set the stage for the immune dysfunction that led to the immune response in the first place? And again, as you know, that takes us back to many times a microbial conversation and the integrity of the immune system within the GI tract as a whole. And so it's interesting about the food allergy component. That was something that I used to put a lot of emphasis on in my practice. But as I've grown in my experience, it's interesting. I don't really look for food allergies as much anymore. And I find that I can still get the outcomes with patients without having to have the patient follow up on those types of testing models.
And you mentioned neurological disorders as a light bulb going off for you with a patient. Which of those neurological disorders trigger that response for you to think about SIBO?
Probably the biggest one. Let me actually give you two, one that's obvious and one that's not. The first one, the obvious one, would be Parkinson's disease. And some of these patients that are starting to show early manifestation, changes in dopamine activity, those would be the more obvious one on this. And the less obvious neurological relationship would be diabetes. And most would look at that and go, well, that's an endocrine disorder. That's a disorder of glucose and insulin. And I don't disagree with that. It is. But when we look at the dysfunction that is linked to that, we often find that there are changes in the nervous system, what we would classify as the enteric nervous system in and around the gastrointestinal tract. So whether we're talking about Parkinson's or whether we're talking about a side effect, if you will, of diabetes, what ends up happening in both of these cases is that you change the dynamics of motility because the neurological input into the enteric nervous system has been altered. And so the bowels become slower. They don't have that consistent stimulation from the nervous system to promote peristalsis, the normal motility of the gut. And as a byproduct, you just don't get the transit time. And if things don't continue to move through the GI tract within a reasonable time, then you start looking at you begin to lack this flushing response that happens in the small intestine to keep bacteria moving towards the large intestine. And if you lack that, then they start building up in the small intestine.
Okay. So if somebody suspects or you suspect a patient has a problem, what is the first step for testing to clinically verify that they do have SIBO?
You know, I thought about the answer to this question, and I'm going to give you probably a controversial answer on this question because I am very atypical in how I approach this, but I feel like I have just reason for that. So let me explain. So I actually don't test patients with this, but testing does have a place, but I think you have to understand that there are limitations behind testing as well. So in general, we can work off of symptoms. We can set up an empirical protocol for the patient. We can implement that, and we can see whether they respond to that or not. That's a fairly common strategy in all of healthcare. You have an infection, we'll put you on an antimicrobial. Let's see if you respond to it. If we want to take the first level of testing and look at testing that we would consider non-invasive, that's going to have us looking at things like glucose breath test or hydrogen breath test. And then if we want to take a more invasive route on that, we can do what's called an upper GI aspirate. So they're actually taking a sample. Nobody's honestly signing up for that. That's not really a clinical thing that anybody's doing. But it does bring the conversation back to the non-invasive testing, which are the breath tests. And the breath tests have a role, but again, you have to understand their limitations. So here's where the limitations come in, is that let's take the glucose breath test. Glucose is absorbed in the first 3 to 6 feet of the small intestine, but the small intestine is 19 feet long. So that means that we have potentially somewhere between 13 and 16 feet of the small intestine that are going unaccounted for. So that's over 2/3 of the small intestine that is not being assessed with a glucose breath test. And that can be problematic because someone may take that test and it comes back negative and they say, hey, well, I don't have SIBO. Maybe you still do because we didn't actually assess the majority of your small intestine. So this is why I don't lean heavily on those tests. They have those limitations. And if we implement a sound antimicrobial protocol, a lot of times we can sidestep those limitations and just bypass the whole testing process in the same time.
So if somebody opts to do the SIBO protocol without testing, because testing can be problematic or not find what we're looking for, is there any downside for somebody to take the protocol? Does it cause any issues with the large intestine? Can it be problematic in other areas? How do you overcome that?
So in general, these protocols don't have to be extremely harsh, and they don't have to be long in duration. And those are the typically two main problems we see with antimicrobial protocols, is that if they're implemented for too long a period of time, they are going to begin to significantly negatively impact the commensal or the beneficial species in the GI tract. Keep in mind that what we're talking about here are bacteria, and of the not pathogens, but of the microbes that we encounter in clinical practice that we need to try to manipulate the profile of. Bacteria are not that difficult. They, by and large, respond pretty effectively to most non-pharmaceutical antimicrobials. And so if we put those in for 30 days, using things like oil of oregano, caprylic acid, some of these compounds that have a history of effective use, but they're just not going to wipe out everything in the gut. That's what we're looking to apply here. So duration and level of the antimicrobial.
Okay. So relatively safe as nutritional supplementation. And if somebody has a negative effect from the protocol, let's say, for example, they start this and 10 days later, they're like, I'm having more diarrhea, I'm having, greater distension. Where does your brain go from there? What are you thinking?
Yeah, there's two directions we can go with this, and maybe even three. I'll actually give you a third one. So the first direction is we can just slow down. We can take that protocol, we can cut it in half, and we can extend the duration of the protocol. Not uncommon to have to do that. That some individuals, that is the direction we take. So that's the first option. The second option is, and I do this one very commonly, is have a stool test. That stool test is going to help us understand what other dynamics are taking place in the GI tract. Maybe this is a scenario where there is some inflammatory dysfunction that is being noted. For example, let's say that patient has some degree of inflammation in the gut. It's significant enough that it's impacting the tissues in the gut, and we start eliminating some of these species that are considered part of small intestinal bacterial overgrowth. As those species die off, they begin to overwhelm the immune system in the GI tract in some patients, and that can add to the inflammatory load. So this is pretty common. We call these things lipopolysaccharides in a lot of instances. This is a more specific name for those. So those I would say are probably my two first directions to go. And then the third option is just change antimicrobials. There's so many antimicrobials that are effective when it comes to SIBO that if someone doesn't respond well to one, there's nothing that says that we have to stay locked into that as our option. We can just shift gears.
Okay. And on the research that you shared with me in prep for this interview, there are a host of other maladies associated with this condition, including one that I was really surprised to see, which was non-alcoholic fatty liver disease, or NAFD. And I wanted you to talk about that with me and share with me the reason why, like the underlying reason why SIBO and NAFD are related.
This comes back to a term that we look at as calling endotoxemia. And so literally what that is suggesting is that the patient is becoming toxic within their own body. How this happens is based in and around what we call the gut-liver axis. So I only bring that up because many individuals have heard about the gut-brain axis, and there's also a gut-liver axis, and it is just as relevant. So what that suggests is that what takes place in the gastrointestinal tract has a very profound impact on the liver. How this endotoxemia, this becoming toxic from within, how this manifests is that these organisms that are a part of SIBO are producing byproducts. And probably an interesting segue, I mentioned the word lipopolysaccharides, these things that are abbreviated LPSs. These are actually many times the driver for the dysfunction that takes place in the liver. So those LPSs find their way to the liver. They drive these inflammatory cascades in the cells of the liver and begin to damage those liver cells. And one of the things that can start to happen here is we can see an accumulation of ammonia. So you combine this accumulation of ammonia, which is neurotoxic, you couple that with the damage to the cells, and over time, those cells are less functional. There's fewer capable cells in the liver. And if this progresses for a long enough period of time, you can actually start to develop fibrotic tissue in there as well. But it all goes back to those overgrowth of organisms in the small intestine. And I just want to underline in these comments that this goes back to the statement that you made that this is not a benign condition. There are real significant implications of not following up on this.
Sure. So I have a weird way to break this down a little bit for the layperson, and correct me if I'm wrong. I'm going to go backwards for a second. I had a guest on my show who does live blood cell analysis down in South Florida. I remember him saying specifically that he can see poop from microbes in the blood, and that causes toxicity. Is that what you're referring to with, is it basically microbial poop that's running around that causes the liver to become dysfunctional and inflamed over time? Or is that the worst way to describe it?
That might be the worst way to describe it. I'll give you two more ways to think about this. These bacteria are either, these LPSs can become a byproduct from one of two things. And these can be problems in and of themselves. They're either metabolites, so there's something toxic that the bacteria itself is directly producing, or when that bacteria is going through its life cycle and it's replicating, once it gets to the point where it dies off, it will actually shed a component of its cellular structure, and that component of the cellular structure becomes an immune system trigger as well. So I would say it's either a metabolite or a byproduct that we should be thinking about here.
Okay, because I was thinking more waste material, and that's oversimplifying it then.
I think it may be, but I mean, I guess, and to your point too, these are waste materials because naturally, it's not totally uncommon to find these organisms that we're talking about that are part of SIBO. So I want to make that clear. It's common to find these, and it's expected to find these organisms. You just shouldn't find them in the quantities that we're talking about that contribute to SIBO. So we may see some of these LPSs in the blood. It's acceptable to have measurable levels of these in the blood, and the body can handle that. It circulates around through the liver, detoxes it, and you dump it out in the small intestine and excrete it out. But when that threshold becomes so high for what is getting produced and that the body has to try to manage, it just can't keep up.
Gotcha. So when it comes to non-alcoholic fatty liver disease, I know that the liver is a very highly regenerative organ and can respond very favorably to different types of therapies. In the case of SIBO causing problems with liver fibrosis, can you arrest that fibrosis? Can you reverse that fibrosis? And do you address that with NAFD?
I would say simply in the majority of patients that show up to our door, the answer is yes. Where the answer would be no is that when we're talking about a very far progressed end stage fibrotic situation, maybe even moving into a cirrhotic type of profile. But for typical non-alcoholic fatty liver disease, yes, we can undo this. So, and the easy way to think about this is that just as problematic as the bacteria can be, the overgrowth of the bacteria can be for the liver, when the right profile of bacteria are there, they can equally be beneficial to the liver as well.
Got it. So can you talk to me about the potential etiology of this condition and how it relates to hypochlorhydria and how intermittent fasting or fasting either helps or hurts this condition? When I was reviewing your notes, I was a little confused whether or not the fasting was good or bad.
And it's an interesting conversation. Let me tackle the etiology question first, and that'll lead us right into the fasting conversation. The etiology behind this, a lot of times, I define this with patients as the breakdown in your defense lines in your upper GI tract. So what I mean by that is that there's three of these. You have acid in the stomach, you have enzymes from the pancreas, and you have bile from the gallbladder. All three of these gastric secretions they're not only there to support breakdown and digestion of food, but they're also there to be able to kill off organisms, a large percentage of organisms that are going through your GI tract, through the upper GI tract. When someone is under high stress or someone is under or dealing with one of these conditions that we've talked about, the release of that acid is not going to be as significant as it needs to be. The pH doesn't drop down low enough. The gastric environment, the stomach environment doesn't become acidic, and you don't kill these organisms off. And so if you couple that with not having adequate bile production or not having adequate enzyme production from your pancreas, every one of those defense lines that is missing only opens the door further for these organisms to begin to populate in the small intestine. And once that happens, they're off and running. They're bacteria. They proliferate. That's what bacteria do. And they have a constant food supply coming in from the food that we eat, and they are literally outcompeting us for resources. So that's what happens a lot of times as far as the etiology on this. Now, you can add to that all the things that we talked about, that slow down motility in the bowels as well. Hypothyroidism, hormonal changes, neurological dysfunction. These are all going to make the situation worse. Where we start to begin to think about interventions is, and this is why I like stool testing, is that even in a SIBO case, is that I know what I'm going to do on the antimicrobial side, and I know how to manipulate if I have to, but I also need to know what it is that I need to repair for that patient so that we don't relapse again. And this is an important point. The literature shows that 44% of individuals that are treated for SIBO relapse within 9 months. That's a very short relapse time.
And you're talking about traditional therapies that cause relapse, not nutritional therapies, correct?
Well, no, it can even be nutritional therapies, because if we don't address the underlying dysfunction, for example, these gastric secretions with the acid, the bile, and the enzymes, if we don't address those, then it doesn't matter if it was a conventional or a conventional or non-conventional antimicrobial approach, we're still setting the stage for it to remanifest again. And so I want to know, does that patient have enough acid? If not, I want to give them some betaine hydrochloride. We want to start replacing that. If they don't have enzymes, we want to use some of the pancreatic enzymes to help them rebuild. And then if we see that they have fat in the stool, that's a clear indication that their bile production is problematic, and we replace bile for a period of time with the intention that we're going to ultimately allow them the ability or help them regain the ability to be able to produce these things on their own, which is the ultimate goal with this. Now,
got it.
As a part I want to answer your fasting thing really quick on this because I think it's a really good question. We obviously have to account for the diet part of this too. And remember, we're looking to try to keep this sweeping motion going in the small intestine and moving things down into the large intestine and excreting them out. That doesn't happen if we're constantly eating. So what I typically will recommend to patients here is eat your 3 main meals, but don't snack, and stick to eating optimally within daylight hours. So that way you give yourself enough of a window to optimize that flushing motion to help move those overgrowth of bacteria out of the body through the large intestine.
Okay. Do you find a link between people that have jobs where they work odd hours and increased in SIBO likelihood? For example, a firefighter that might have to work a shift where they're working 18 hours and they're not getting either their nutrition is lacking or they're not sleeping as well, or people in the military that maybe have to be on for periods of time and not have that regulatory eating habits and cycles?
Unquestionably, yes, on this. That work pattern is inherently problematic. When we start manipulating our light and dark cycles, we're going to have implications associated with that. It's going to affect our hormone activity. It's going to create undue stress responses that are sometimes unperceived by the individual. It's going to change the dynamics of digestion. So it's not uncommon for individuals that are in that work pattern to be dealing with SIBO.
Got it. So in closing, I mean, we've covered a lot of territory. I feel like we've helped the layperson really get an idea of how this begins, what's happening inside the body, how it can be treated. I know that you've been working with Biotics Research Corporation for quite a while. I've been using the products for the company since I started in acupuncture 25 years ago. I had the pleasure of meeting Dennis McInerney, and he was my mentor for a long time. And I'm sure you know who he is and who he was. And I'm very thankful I got to meet him. When someone contacts me and they say, hey, Tammy, I've got something going on. I think I might have SIBO. I watched your video. I heard what Dr. Hill had to say. What's the first step? What should they do? I usually would assess a patient either telehealth or in person, and then determine based on my ability to diagnose and treat a patient through holistic methods and functional medicine and nutritional therapies and traditional Chinese medicine, where they would go from there. Is that the same? Is that what you would recommend for someone that's got a problem like this?
It is. And what I would stress for the patient or potential patient to consider on this is that when they're looking at that antimicrobial approach to manage the SIBO, that's only phase 1. Dealing with SIBO is in reality a 3-phase process. We have to do the antimicrobial part out of the gate, but then phase 2 is looking at addressing some of these areas like the need for acid, the need for bile, the need for enzymes, the motility in the bowels. How do we help that patient in phase 2 not relapse to where they're currently finding themselves at? And then phase 3 is looking at addressing what I call collateral damage. So whether we're talking about insults that have happened to the organ tissues, or whether we're talking about correcting nutrient deficiencies, any of these things that have manifested as a byproduct of that patient's SIBO presentation, we have to deal with that for them as well.
Okay. So basically, good diagnosis, good listening skills, doing body chemistry analysis, and also basically looking at blood work for optimal or non-optimal levels.
That's it. Okay. And I think you nailed it when you said the good listening abilities, because this is truly one of those conditions. If practitioners listen to their patients will tell them when they need to follow up with SIBO.
Yeah, I find it interesting, as a side note, that a lot of the patients that I see, because I spend a lot of time with them because I'm not constrained by the managed care system as a whole. I see patients outside of that, that they appreciate the listening part, because a lot of practitioners outside of holistic medicine aren't really trained to listen very well. They're much more interested in statistics and data points and getting everything locked into the computer and set. I can't tell you how many people that see me and they're like, you're the first person that's ever listened to me for more than 5 minutes. And, they'll just tell you everything under the sun. And it's refreshing for me to hear somebody say that, because I take that for granted because I do what I do for so long that I don't think about it. And I probably, knock on wood, haven't seen a doctor in quite a while. I've done a telehealth with a practitioner that's, she listens as well, but I haven't had to go to an ER or go to, a traditional urgent care or something like that in quite a while. So I'm glad.
The world needs more practitioners that listen to patients.
Agreed. So I'd like to have you come back and talk with us about some more things. I know you've got other things under your wings that you do as far as research and patient care. So I'll invite you to come back in a couple of months and maybe we can address something new.
Sounds good. I look forward to it.
I appreciate it. Thanks so much.